If you break your arm, an X-ray gives you this really comforting binary answer.
Oh, absolutely. It's very clear cut.
Yeah, it shows that jagged white line. The doctor points to it and says, there it is, broken.
Right.
But if you, or someone you love, suffers a severe tear during childbirth, like a complex pelvic floor trauma, that medical certainty just completely vanishes.
It really does.
You step into this healing landscape that is notoriously murky. And for generations, the medical field has essentially just thrown its hands up.
Yeah.
You're often just told to, live with the pain.
Which is, I mean, that is the tragic reality of obstetric trauma, because the pelvic floor is this highly dynamic, weight-bearing hammock of muscle, nerve, and connective tissue.
Right.
So when a complex injury occurs, it doesn't snap cleanly like a femur. It frays, it shreds. And it happens in an environment subjected to constant physical stress, moisture, and pressure.
Which brings us to the mission of today's deep dive. Welcome in, everyone. We are looking at a breakthrough in biotechnology that proves the old narrative of just living with it is, well, it's becoming scientifically obsolete.
Yeah, thankfully.
Today, we are exploring this massive question for you. Can exosome therapy actually reduce fibrosis and scar tissue contracture following complex perineal tears or episiotomy repairs from childbirth?
And to answer that, we're synthesizing a really fascinating stack of sources. We're diving into preclinical studies on porcine soap pig models from the Female Pelvic Medicine and Reconstructive Surgery Journal.
A great journal, yeah.
Right? And we are cross-referencing that with deep immunological research on wound healing from frontiers in endocrinology and stem cell research and therapy.
Nice.
And finally, we're looking at how clinical practice overviews from regenerative wellness centers are, translating the science into real-world recovery.
Because if you have navigated the aftermath of a severe 3rd or 4th degree perineal tear or an obstetric anal sphincter injury, you already know the stakes here.
Exactly.
The traditional outcome of that difficult healing process is rigid scar tissue. The body panics, throws down a chaotic web of stiff collagen just to close the wound quickly, and you are left with fibrosis.
Right, and that fibrosis is what leads to chronic pain, loss of elasticity.
Severe dysfunctions, right?
Yeah.
Like urinary or bowel incontinence.
Yes. It fundamentally changes the architecture of a person's body. But the sources we're looking at today suggest that we now possess the biological tools to actually intervene in that panic response.
Wow.
But to understand how we can heal these specific complex traumas, we first have to discard an outdated concept in regenerative medicine. Because for years, the gold standard was thought to be stem cell therapy.
Right. The idea being that you take live mesenchymal stem cells, or MSCs, and inject them directly into the wound, hoping they grow into fresh tissue.
Exactly.
But let's look at the environment of a fresh perineal tear. It's inflamed, it starves of oxygen, and it's under mechanical strain. Taking live, delicate stem cells and throwing them into that hostile environment seems, well, incredibly risky, doesn't it?
It presents massive translational bottlenecks. I mean, direct live cell transplantation suffers from incredibly poor in vivo survival rates.
Because they just die.
Yeah, the cells simply die in that harsh hypoxic environment. And beyond that, you have inherent immunogenicity. The patient's immune system might recognize the cells as foreign and attack them.
Oh.
And most concerningly, there's a potential tumorigenic risk. Live stem cells are incredibly potent. If they misread the chaotic chemical signals in a damaged pelvic floor, they could theoretically begin to replicate improperly and promote tumor growth.
Not to mention the logistical nightmare of it all. I mean, live cells require strict, highly expensive cold chain storage to keep them viable. A rural clinic isn't going to have $1 million cryogenic incubation facility just sitting in the back room.
Right, and that realization is actually what shifted the entire field of regenerative biotechnology. Researchers discovered that stem cells don't necessarily stay at the wound site, set up camp, and transform into new tissue. Instead, they operate more like cellular paramedics. They arrive, they assess the localized damage, and then they secrete tiny, naturally occurring lipid vesicles to orchestrate the actual repair process.
And those vesicles are the exosomes.
Yes, exactly.
So if I'm visualizing this, for decades, we treated the stem cells as if they were this massive manufacturing factory, right? We thought we had to uproot the entire factory, load it onto a truck, and transplant it directly into the pelvic floor just to get the healing material.
Which is wildly inefficient and, as we discussed, clinically dangerous.
Exactly. But exosomes are the specific packages the factory ships out. You don't need the whole building with all its volatile machinery. You just need to deliver the right instruction packages to the local construction crew that's already on site.
That is a brilliant way to frame it. Exosomes are nanosized, measuring just 30 to 150 nanometers. And the crucial clinical advantage here is that they are cell-free.
Okay, so what does that mean practically?
Well, because they lack a nucleus, they cannot replicate. And without a nucleus, there is zero risk of live cell rejection and zero risk of tumorigenicity. They can't mutate. They are simply biological delivery shuttles wrapped in a protective lipid bilayer.
Wait, if they aren't live cells, what exactly is the payload inside these shuttles? Like, how are they communicating with the damaged tissue?
They carry highly complex biosignaling instructions. It's a concentrated payload of messenger RNA, microRNA, regulatory proteins, and growth factors derived directly from those parent stem cells.
Oh, wow.
And because they're just lipid vesicles, they're remarkably stable.
Right. I noticed in the clinical practice overviews that they use a process called lyophilization. Explain how that works, because preserving microscopic lipid bubbles sounds like a really delicate process.
It is, yeah. Lyophilization is essentially sophisticated freeze drying. Scientists use specific cryoprotectants, think of it as molecular antifreeze, to remove the water from the exosomes without allowing destructive ice crystals to puncture that fragile lipid bilayer.
Oh, that makes sense.
Yeah, and once lyophilized, this regenerative payload can be stored in a standard medical freezer at -20 degrees Fahrenheit for up to 6 months without losing its biological potency.
Which completely democratizes access to this therapy.
Yeah,
A doctor doesn't need a live cell incubator. They just pull a vial from a standard freezer.
exactly.
And we need to contextualize the scale of this for a moment. According to the sources, a standard clinical application contains between 5 trillion and 15 trillion purified microvesicles.
Yeah.
Trillions. Just picture that scale. A single millimeter of a torn episiotomy isn't just getting a few ambient healing signals. It's being completely saturated by billions of microscopic instruction manuals all at once, actively commanding the tissue to rebuild.
It is a profound density of biological information.
Okay, but delivering 15 trillion packages to a wound site is an incredible logistical feat. But delivery is only half the battle, right? Once those packages open in a frayed, torn pelvic floor, what stops the body from just doing what it always does, panicking and building rigid scar tissue?
To understand that, we have to look closely at the cellular machinery of a scar. When pelvic tissue tears, the body activates fibroblasts, which are the primary builder cells.
Right.
In a state of acute trauma, they differentiate into a highly aggressive form called myofibroblasts. And these cells are responsible for rapid wound contraction. They indiscriminately dump thick, disorganized collagen into the gap just to seal the breach.
Wait, let me push back on this premise for a second, though. If you suffer a complex childbirth injury, like a fourth-degree tear that goes all the way through the vaginal wall and severs the anal sphincter, don't you need a massive, rapid scar just to close that structural gap?
Wow.
Like if exosomes are stopping fibrosis, doesn't the wound just stay open? Doesn't the tissue just fall apart under the weight of the abdomen?
That paradox is what makes exosome therapy so revolutionary in wound healing. The key distinction is that exosomes do not stop the healing process, they regulate it. They act as a biological dimmer switch, not an off switch.
A dimmer switch.
Yeah.
Okay, how does that biological dimmer switch actually engage within the cell?
It involves a very specific signaling pathway in the body called the TGF-beta's MAD pathway.
Okay.
Transforming growth factor beta-1, or TGF-beta-1, is the primary alarm bell. When that alarm rings, it triggers the fibroblasts to become those aggressive, scar-producing myofibroblasts.
Got it.
Now, the exosomes we're discussing are loaded with specific snippets of genetic code called microRNAs specifically, molecules known as miR-2045P and miR-12815P.
And microRNAs act to silence or degrade other genetic messages in the cell, correct? Like they intercept instructions before they can be executed.
That is their exact function. When the exosomes enter the fibroblasts at the wound site, they release those specific microRNAs.
Okay.
These molecules seek out and selectively degrade the messenger RNA that produces TGF-beta1. So by suppressing that alarm bell, you create a negative feedback loop that blocks the downstream signaling of the SMAD2 and SMAD3 proteins.
Okay, so if we translate that, the SMAD proteins are basically the biological foreman on the construction site, right?
Yeah.
Constantly shouting at the cells to dump more stiff scar tissue into the wound. So by silencing the alarm, the foremen are quieted down. The fibroblasts don't get the signal to panic and over-differentiate.
Precisely the right way to think about it. And here is the profound shift in the biological cascade. Because the fibroblasts remain in a regulated, calm state, they change the type of building materials they use to repair the tissue.
What do they use instead?
Instead of relying on disorganized, stiff collagen, the exosomes boost the production of collagen first, collagen third, and elastin.
Elastin. That is the magic word for pelvic health. The ability for tissue to stretch and rebound.
It is arguably the most critical component. This modulation ensures that the tissue heals with the necessary biomechanical strength to hold together so the wound does not fall apart, answering your earlier concern.
Right.
But because of the organized collagen, the third, and the elastin, it heals with flexibility. It can handle the dynamic physical stress of daily movement, lifting, and bodily functions without the rigid scar contracture that causes long-term agony.
It makes me think of repairing a torn piece of fabric. The body's natural panic response is to fix the tear with a thick, stiff glob of industrial superglue.
Yes.
It holds the fabric together, sure, but it ruins the flexibility of the garment. What these exosomes are doing is forcing the body to meticulously reweave the original threads so the fabric stretches and moves exactly like it used to.
A very elegant visualization, but, preventing that long-term rigid scar is only addressing the chronic phase of the injury. We also have to consider the immediate acute phase.
Right, because minute one of a severe episiotomy repair is a crisis.
Absolutely.
Tissue is severely inflamed, there's massive localized swelling, and the blood vessels have been severed, meaning the tissue is starved of oxygen. How do these instruction manuals handle that immediate emergency?
This brings us to what the immunological research refers to as the biological envelope.
You always light up when we talk about the biological envelope. Break that concept down for us in the context of a fresh perineal care.
I love it because it's just brilliant. The biological envelope refers to the entire holistic microenvironment of the wound bed.
Okay.
It encompasses the immune cells, the severed blood vessels, the extracellular matrix, the chemical signaling, everything interacting in that highly localized space. And exosomes are master reprogrammers of this envelope. Their very first target is a specific type of white blood cell called the macrophage.
And macrophages are the immune system's first responders, right? They engulf cellular debris and dictate how the rest of the immune system reacts to the injury.
Yes, and they operate primarily in two different states, or phenotypes, M1 and M2.
Okay.
M1 macrophages are essentially the pro-inflammatory SWAT team. When trauma occurs, they flood the area, release massive amounts of inflammatory cytokines like TNF-alpha and IL-6, and aggressively attack any potential pathogens.
Which is good at first, right?
Oh, this response is critical for the first few hours to prevent infection. But in severe traumas, the immune system gets stuck in this M1 phase. The inflammation becomes chronic, which actively halts the regenerative process. So the SWAT team refuses to leave the building. They keep deploying inflammatory weapons, and as a result, the construction crew can't get inside to actually start repairing the damage.
That is the exact bottleneck. But what the data shows is that the biological instructions within these trillions of exosomes actively force the macrophages to shift polarization. They force the macrophages to drop their weapons, the inflammatory TNF-alpha, and switch to the M2 phenotype.
And what is the role of the M2 phenotype?
The M2s are the cleanup crew. Once polarized to M2, these cells begin pouring out a molecule called IL-10. You can think of IL-10 as a powerful biological coolant.
A coolant, I like that.
Yeah, it rapidly reduces the localized swelling, pain, and redness in the pelvic tissue, calming the entire environment down so repair can begin.
But calming the inflammation doesn't solve the issue of the severed blood vessels. A severely torn perineum is ischemic. It lacks blood flow.
Which is the next phase of the envelope reprogramming. To fix the ischemia, the exosomes trigger a process called angiogenesis, which is the formation of new blood vessels.
Yeah, the microRNAs delivered by the exosomes activate the VEGF pathways. VEGF stands for vascular endothelial growth factor. When this pathway is triggered, it forces the surrounding endothelial cells to migrate into the wound and build entirely new sprawling capillary networks throughout the damaged pelvic tissue.
We really need to emphasize how critical that is for you listening. Restoring blood flow isn't just about bringing oxygen and nutrients to the cells. It's about restoring actual sensation and functional health.
Exactly.
We cannot have healthy, sexually responsive, or functionally sound tissue if the microvasculature has been destroyed by trauma and replaced by an avascular, numb scar.
Right. And if we pull all these threads together, we see a multi-pronged biological intervention. By modulating the TGF-beta scar pathway, shifting the immune response to the M2 cleanup phase, and triggering VEGF angiogenesis,
Yeah.
exosome therapy completely overrides the body's flawed trauma response.
It's amazing. But this cellular choreography sounds absolutely perfect when we discuss it as a theory or when it's observed in a petri dish. Yeah. But a human pelvic floor is incredibly complex. It bears the weight of the internal organs, it's constantly moving, it's subjected to moisture and bacteria from the GI tract. Do we have proof that this translates to that specific, highly stressed environment?
We do, and this is where the preclinical studies from the Female Pelvic Medicine and Reconstructive Surgery Journal provide such crucial validation. Researchers at major institutions have been running highly controlled studies using porcine models to test this exact application.
Why are we looking at pigs to understand human pelvic floor injuries, though?
Because it is the closest biomechanical analog we have. A pig's anatomical structure, the way their pelvic floor bears weight, the intra-abdominal pressure gradients they experience, and their distinct phases of wound healing are remarkably similar to humans.
Really? I didn't know that.
Yeah, it is far more accurate than testing on a mouse or a rat before moving to human clinical trials. And importantly, these studies didn't just look at superficial cuts. They modeled severe, complex traumas, including vaginal mesh exposures and obstetric anal sphincter injuries.
Oh, obstetric anal sphincter injuries. Those are the devastating tears we mentioned earlier, the ones that extend completely through the vaginal wall and tear the muscle ring of the anus.
Yes.
They are a primary cause of severe bowel dysfunction in mothers. The fact that researchers are modeling this specific trauma is a massive step forward. What do the data actually show?
Let's focus on a specific data point from the vaginal mesh exposure study. The researchers implanted surgical mesh into the vaginal walls of the pigs to create a severe, highly inflamed, non-healing wound.
Okay.
They then divided the subjects. One group received standard surgical closure, which means simply stitching the damaged tissue over the wound.
Right, the usual approach.
Exactly. The other group received surgical closure plus localized exosome therapy.
And the physical results.
The contrast was staggering.
Right.
In the group that received only standard surgical closure, the regenerated epithelial tissue was exceedingly thin, measuring only 80 micrometers thick. The tissue remained structurally weak, highly inflamed, and in many instances, the wound simply tore open again under the physical stress, re-exposing the mesh.
Because the tissue they relied on was just that rigid, disorganized scar tissue that lacks elasticity, right? It just couldn't handle the physical load.
Precisely. But in the group treated with the exosomes, the regenerated epithelial tissue measured 208 micrometers thick.
Wait, 208 versus 80, that's more than 2.5 times thicker.
The volume of regeneration was massive. Furthermore, it wasn't just thicker tissue, it was functionally healthier tissue. The capillary density in the exosome group was significantly higher, proving that those VEGF angiogenesis pathways we discussed were actively building new blood vessels to sustain the tissue.
That's incredible.
And using cellular tracking markers, they confirmed this was de novo regeneration.
De novo, meaning from scratch.
Yes. The tissue was essentially rebuilding itself from scratch, with minimal inflammatory and fibrosis responses compared to the surgery-only group.
It really makes me think of trying to fix a blowout on a flat tire. If you take a standard surgical approach, just suturing a complex tear, it's like slapping a rubber patch over the blowout hole with some cheap glue.
Yeah.
Yes, you're covering the hole,
Yeah.
but you're leaving the structure inherently weak. The moment you put the weight of the car on that tire and try to drive, the patch is just going to blow right off because it hasn't integrated with the tire wall.
That is a very apt comparison for the pelvic floor, which is constantly under the immense pressure of the abdominal cavity every time a person stands, coughs, or lifts something.
Right, but when you add the exosome therapy to the surgical closure,
Yeah.
that's like taking that damaged tire and completely revulcanizing the rubber at a molecular level.
Exactly.
The new biological material melts seamlessly into the old material. It's fully integrated, it remains flexible, and it functions exactly like it's brand new.
And that structural integration is exactly why we're seeing these therapies begin to transition out of preclinical models and into specialized regenerative wellness practices.
Oh, so it's already happened?
Yeah, while wide-scale clinical adoption takes time, cutting-edge clinics are already utilizing these highly concentrated, single-donor exosome formulations as post-procedure adjuncts to reconstructive pelvic surgeries and episiotomy repairs.
Wow. So let's bring this massive topic all together for you, the listener. We started by looking at the frustrating, painful world of postpartum pelvic trauma, the severe perineal tears, the deep episiotomies, and the resulting scars that, Well, they rob people of their comfort and bodily function.
And what we have uncovered in the source material is that exosome therapy represents a monumental leap forward in regenerative medicine.
Right. By utilizing tiny, cell-free lipid vesicles, we can deliver very specific biosignals directly to the trauma site.
Those microRNAs act as biological interceptors. They act as a dimmer switch on fibrosis by quieting the SMAD formin.
They force the immune system SWAT team to drop their inflammatory weapons, transitioning into a cleanup crew that cools the tissue down.
Exactly. And they trigger the growth of fresh blood vessels, bringing life and sensation back to the area. They allow the body to repair complex tears with flexible, durable elastin rather than painful, rigid scars.
This science completely shifts the paradigm of postpartum care. We're moving away from the structural limitation of merely suturing a wound closed and, hoping the body figures it out. We're entering an era of true, targeted cellular restoration.
It's a huge step.
It's a profound shift from you just have to live with the discomfort to actively providing the body with the exact genetic blueprints it needs to rebuild itself perfectly. And as we wrap up this deep dive, there's one final mind-expanding thought from the research that I really want to leave you with.
Yeah, the trajectory of this technology raises an incredible question about where biotechnology goes next.
Right. We know that right now, these 30 to 150 nanometer exosomes are acting as brilliant delivery shuttles. But currently, they're carrying the natural mRNA and microRNA instructions derived directly from human stem cells. We're essentially harvesting nature's own healing codes. But if we're already successfully isolating these lipid envelopes, and we intimately understand how they penetrate and reprogram the wound microenvironment,
How long will it be until we stop relying entirely on natural stem cells to fill those envelopes?
exactly. How long until we can synthetically load these lipid envelopes with custom-designed lab-made RNA payloads?
Wow.
Imagine a future where a doctor doesn't just give you a generalized regenerative exosome treatment. Instead, they essentially write an on-demand synthetic software update, perfectly coded to heal your specific individual pelvic trauma.
It represents the ultimate evolution of the technology. We are moving from simply harvesting biological signals to actively programming them.
Suddenly, that murky diagnostic landscape we talked about at the very beginning of the show, it doesn't look so murky anymore. In fact, it looks like it's about to be mapped, engineered, and healed with absolute molecular precision. Something for you to mull over as you go about your day. Thanks for joining us on this deep dive. We'll catch you on the next one.